Don't narrow your approach to asymptomatic carotid stenosis. A 70-year-old female with a past medical history of hypertension, hyperlipidemia, coronary artery disease with stent placement, and who is a current 1-pack per day smoker presents to her neurologist in clinic. She endorses recurrent episodes of lightheadedness over the past 6 months. These are not positional or associated with weakness, numbness, vision changes, or word-finding difficulty. She is taking aspirin 81 milligrams for a coronary artery disease. She undergoes diagnostic workup. Her blood pressure is 155/90. Carotid duplex demonstrates 60% left internal carotid artery stenosis. How should we consider counseling and further management for her? Asymptomatic carotid stenosis is typically defined as greater than or equal to 50% stenosis of extracranial arteries without a history of ipsilateral ischemic stroke or transient ischemic attack. Risk factors for asymptomatic carotid stenosis include smoking, hyperlipidemia, hypertension, and diabetes. Smoking is a major risk factor for carotid stenosis and can lead to progression of stenosis and ipsilateral cerebrovascular events. Medical management to control a patient's risk factors should be offered to all patients with asymptomatic carotid stenosis. Current smokers should be counseled on smoking cessation and offered pharmacotherapy. Behavioral health counseling on lifestyle interventions such as diet and exercise, including the Mediterranean diet and moderate intensity exercise, 4 to 7 days per week for at least 150 minutes per week, can help mitigate cardiovascular and cerebrovascular risk. According to AHA guidelines, physicians should target blood cholesterol LDL less than 70 milligrams per deciliter using a high-intensity statin plus ezetimibe or proprotein convertase subtilisin kexin type 9 PCSK9 inhibitor. Additionally, guideline recommendations include a blood pressure target less than 130/80. Consider starting angiotensin converting enzyme inhibitors or angiotensin receptor blockers, which may have benefits in reversing the progression of carotid atherosclerosis. A hemoglobin A1C of less than 7% for most patients with type 2 diabetes is preferred with the use of glucose-lowering therapies including metformin, sodium glucose cotransporter 2, SGLT2 inhibitors, and glucagon-like peptide 1, GLP-1 agonists. Treatment with antiplatelet therapy is unclear, but aspirin may be considered in patients with high-risk plaques on imaging. These plaques are prone to rupture and can lead to atheroembolic events, ipsilateral ischemic stroke, and transient ischemic attack. P2Y12 receptor antagonists such as clopidogrel, ticagrelor, and prasugrel have not been studied in patients with asymptomatic carotid stenosis, although they may be reserved for patients who are allergic to aspirin. Screening for asymptomatic carotid stenosis is not recommended in the general adult population. If asymptomatic carotid stenosis is incidentally found on carotid duplex, high-risk features would include plaque cross-sectional area greater than 40 millimeters squared, juxtaluminal black area, plaque echolucency, ulceration, impaired cerebrovascular reserve, or signs of progressive stenosis. Evidence of microemboli on transcranial Doppler indicated that patients were much more likely to have a stroke during the first year than those without microemboli. There may also be corresponding intraplaque hemorrhage or silent brain infarction on MRI. These features may be useful for selecting candidates with asymptomatic carotid stenosis for possible revascularization. Revascularization methods include carotid endarterectomy, carotid artery stenting, and transcarotid artery revascularization, TCAR. These options may be considered for patients with asymptomatic carotid stenosis with high-risk plaques or symptomatic severe carotid stenosis in the setting of ipsilateral ischemic stroke or TIA. Our patient was counseled on smoking cessation and the benefits of the Mediterranean diet and exercise. Her risk factors were managed medically. She was started on an angiotensin receptor blocker, losartan, for recurrent elevated blood pressure greater than 130/80. Her LDL cholesterol was 160 milligrams per deciliter, so she was started on high-intensity atorvastatin. She continues aspirin 81 milligrams daily for her coronary artery disease and prior stent. She continues to follow up periodically with her primary care provider for further optimization of her risk factors.